Hello, good morning, good afternoon, and good night to everyone. We are going to start the second day of the Research Initiative Spring Meeting. I am Patricia Debs, dermatologist and specialist in cancer disease. I'm a professor at the Federal University of Espírito Santo in Vitória, Espírito Santo State in Southeast Brazil. Along with Dr. Sunil Anand, we would like to welcome everyone here to attend 3 presentations, actually maybe 2, in this session. We will have 2 or 3 presentations of 8 minutes or a little bit more, and 6 minutes of questions for each presentation. So please, you can make your questions at the session. So anyone who has questions or comments can ask them through the Q&A or directly in the chat. I invited Dr. Sunil for a few words.
Thank you, Patricia. Hello, everyone. I'm Sunil Anand. I work as the Regional Director for the American Leprosy Missions. I was once a dermatologist also. I'm happy to be here and looking forward to listening to the presentations and learning from it. Thank you. Over to you, Patricia.
Yeah. So I'd like to invite the first presenter, Dr. Dipak Kumar Biswas, to present the project titled Assessing the Effectiveness of Intensified Extended Contact Survey to Routine Leprosy Case Detection in Bangladesh. So, Dr. Dipak, welcome you. And you have 8, maybe 10 minutes for your presentation. You can share your screen.
Thank you very much for giving me the opportunity to present here in this August gathering. I'm sharing my presentation here. Welcome to the presentation from Damien Foundation Bangladesh. The title of our project is Assessing the Effectiveness of Intensified Extended Contact Survey to Routine Leprosy Case Detection in Bangladesh. Here are the names of the investigators and co-investigators along with their organizations and institutions. I am Dr. Dipak Kumar Biswas, Medical Coordinator, Damien Foundation Bangladesh, presenting on behalf of this team. Damien Foundation Bangladesh has been working in Bangladesh since 1972 and has been conducting routine contact survey since the beginning of the project here in Bangladesh. But till now, what we observed that the proportion of child leprosy cases is still high, is around 7%, and also grade 2 disabilities also high, around 15% in our area. We know that leprosy cases often clusters within neighbors or hamlets, and one recent study confirmed that the clustering beyond household, even up to 100 meters of index case. So this study is intended to identify the missing leprosy cases within this cluster or hamlets through intensive extended contact survey, which is called IECS and called IECS strategy. Let us, just differentiate the RCS and IECS. RCS means routine contact survey, which means that contact survey of the patient's household members and mainly passive. And IECS is contact survey of the household members as well as neighboring communities within the certain limit of boundary. Objectives of the project is main objective to assess the impact of the intensive extended contact survey strategy in reducing the proportion of patients with disability grade 2 at diagnosis. Secondary objectives: 1, to estimate the yield of the IECS strategy. 2, to estimate the cost of the IECS strategy compared to routine contact screening. 3, to assess the feasibility of IECS under programmatic condition. Methods. Damien Foundation Bangladesh is working in 14 districts. We randomly selected 7 districts for intervention and remaining 7 as a control. The study period. Originally, the study period was from 1st September 2019 to 31st December 2023, but later on it was extended up to, it has been extended up to 2024, August 2024, due to COVID-19 situation mainly, and also there was initial delay due for getting some approval from different authorities. The sample size is 656 total. In intervention area it is 328 and control area 328. Now let us see the data collection methods for control and intervention area. In control area, we call the process RCS. Here we collect the data from new leprosy patients as well as their household members. Through a software, Android-based software, we call ODK collect, and there are two forms, one for collecting data from new leprosy patients, which is BD Lab app, and this another one for household members, which is called BD Contact Lab. So after collecting this data through the Android set, we check it for correctness and then upload the data to the ITM server. In intervention area, we follow the IECS strategy, that is Intensive Extended Contact Survey strategy. Here we collect the data from new leprosy patients as well as from their household and surrounding community people. The data collection from the new leprosy patient is same as control area, but in addition to that, we give a GPS tracker to the patients to collect the geographic position of the houses of the patients, and then collect the information through the GPS tracker. This information, this data is downloaded in the computer, and here we process it to create a buffer file, which shows the actual boundary to be screened. And this file is transferred to the Android set, and through this Android set, the staff know which area to be screened and around the patient's house. Then they conduct the IECS with the help of this Android set. And all the data collected from the patients and from the households and community members collected through this Android set again and uploaded to the server. This is the picture of the Android set view of the outline of the hamlet. You see here is a small hamlet where less than half kilometer or something like that. So we outline the whole hamlet here to screen the population. But in case of the big hamlets, which is beyond the half kilometer or more, 1 or 2 kilometers, so we select a small area of 75 radius area, like a circle like this. This is the first patient. But if we get a secondary patients within this boundary, then we expand this circle again. And in this way, we expand this to cover the area. Now let us see some findings so far. What we observed that the COVID-19 situation seriously affected the case finding, so we could enroll only a less than 50% of the target of sample size. And what we observed that the intensive extended contact survey, the IECS was seriously affected, is more affected than the RCS, because in case of RCS, it is conducted within the family members of the patient who have some contact with our clinics and with the program. But in case of IECS, we also examine the community people. So during the COVID-19 situation, it was very difficult to have access to the community people. That is why in intervention area, the sample is, the enrollment is less. Total enrollment was 309. In intervention, it was 132, 43%. And in control area, it was 177, 57%. The family size all over, it was 5.6. In intervention, we found that it is 6.16, and control area, it was 5.22. Female-male ratio was more or less same in both the areas. In intervention area, it was 1:1.39. In control area, it was 1:42. Regarding the yield from IECS and RCS, what we observed that in IECS area, we could conduct this survey among the 97 index cases. Total contacts are surveyed 8,502, but only 10 cases we have found there. And in control area, we conducted RCS. Index cases are 146. Total number of households surveyed, examined 514, but we only get 5 cases. So if we compare these two, in IECS intervention area, the cases are more than the RCS area. So this indicates that there are more cases in the community level, which we don't identify usually through the normal program when we just only survey the household members of the index cases. Regarding the proportion of grade 2 disability, multibacillary cases and delay in diagnosis, what we observe that is little more in intervention area at this stage. And what we observe that, and all our analysis is that in the initial stage it may be more, because in the community level, the patients are remaining for a long time and there is no active case finding method. So people are not coming to the clinic for accessing services. That is why maybe initially stage this is more, but after 2-3 years, if we continue this IECS in community, then it will be reducing. Now, in the concluding remarks, I would like to say that COVID-19 has a great impact on the project, and enrollment was less than 50%. But the positive thing is that the IECS is more cases than the RCS. So it is important step. If we can continue this IECS without any disturb, then it may be a great help to find out the hidden cases which are not coming to the services. And this may be a great step towards achieving zero leprosy of SDG. Last point is IECS may be feasible to continue in regular programmatic condition with little modification. And the modification like that, we use here the GPS tracker, and also we using a specific step, but in case of regular program, we can modify it. We can find other ways to identify the coordinate and GPS location of the patient house. And also we assign some existing staff to do this contact IECS regular program. So thank you very much for your passion sharing. And if you have any question.
Thank you, Dr. Dipak Kumar Biswas. Dr. Sunil, would you like to coordinate the question and answers session?
Thank you. There are 3 questions. Just to reiterate what Patricia mentioned at the beginning of the session, if you would please post your questions in the Q&A at the bottom of the screen, that'll help. We have 3 questions, 4th one now, but the first one is from Guillermo. How are ethics addressed regarding geodata collection at household level?
We use a GPS tracker. The tracker, it collects the coordinate from the patient house. It is given to the patient, and the patient keeps it for several days, about 1 week in their house. It collects data, and we download this data to the computer and see the coordinate. And with this coordinate, we create buffer files, and we know the GPS positioning of the houses.
Dipak, I think the question of Guillermo's question is about how are ethics addressed regarding the geodata collection. If you could.
Oh, yeah. Yes. While we are giving the tracker to them, we fill up a consent form. We describe the project to them that this is we giving just to collect the position, and we'll use like this, and we have a consent form like for that. I mean, overall consent form, it is mentioned there.
Okay. There's the second question from Yudi. How did you use this IECS and RCS tool? Local healthcare staff or someone who recruited for this purpose?
Could you please again repeat the question, yeah, please?
Who used this IECS and RCS tool? Is it the local healthcare staff or someone else who was recruited for this purpose specifically?
Oh, they are the Damien Foundation staff who are working in Damien Foundation regularly, and we train them to use these tools, and they collect the data from the field.
Thank you. There's a question from Paul. How was the tracker used? Not mentioned in the results.
Tracker just used to collect the coordinate, I mean, geographic position, not for others purposes, just only collect the coordinate. And that is why in the conclusion, I mentioned that we can also find the alternative way to find out the location of the house. Yeah.
And do we have time for one last question, Patricia? There's this question from Ruth Butlin. Was it once-off survey or annual survey of contacts?
Initially, for this project, we planned for once-off survey, but if it continues in the programming condition, we think that it should be 2 to 3 consecutive years so that we can have a very good result.
Okay.
We have time for more questions, I believe.
There are 2 more. Peter Nichols, did you find any differences in outcome between contacts of MB and PB index cases?
At this moment, there is no, difference. Rather, we see a little bit, MB cases are a little bit more in the intervention area. And I also explained the reason of that, because in the community level, usually we do not organize the contact survey. Just we organize the contact survey among the household members. That is why initially maybe it is more, but if we conduct the survey for consecutive 2 to 3 years, then it will be less.
Right, and then one more question from Ruth Butlin. Do you have any information on comparative costs?
Not yet. This year we'll be analyzing the cost. We have not yet calculated the cost yet.
Thank you very much, Dipak. That was really.
Thank you very much.
Any other questions for the audience? No, Nicole. Nicole, you have received a message for hi. Have you seen?
No, we have not been able to trace him yet. So if we could continue with the next presentation, and hopefully then Mr. Aubin will join later.
Yeah, Hi is the co-presenter of the next presentation, and he said that Aubin has troubles joining. So he's asking to go for the next presentation. Yeah, he's on the chat. A message for him. That's fine. So we're gonna move to the third presentation. So I would like to invite Mrs. Josephine on behalf of Dr. Mariama Mahmoud from National Leprosy and Tuberculosis Control Program in Sierra Leone. And Mrs. Josephine will present the project entitled Collaboration with Traditional Healers to Reduce the Delay of Leprosy Diagnosis and Improve Detection of Hidden Leprosy Patients in Sierra Leone. Good morning, Mrs. Josephine, can you hear me?
Hello, everybody. Can you hear me?
Yes, perfectly. You can share your slides, please. You have 8-10 minutes if you need, okay, for your presentation. And audience, please, you can post your questions on the Q&A session.
Hello, once again, I'm Josephine Amikuruma, a public health sister working at the National TB Program. I'm here to present to you our findings and the progress report of the study collaboration with traditional healers to reduce the delay of leprosy diagnosis and improve detection of hidden leprosy cases in Sierra Leone through establishment of a referral system. The lead applicant was Dr. Linda Forey, but she left the program and now it's Dr. Mariama Mahmoud, and the rest of them are all like the GLRA that are co-studying with us for that. These are all members of the project. My presentation will follow this outline, overview of the project, the current status, and the way forward. And in 2002, Sierra Leone met the elimination of getting 1 case per 10,000 below 1 case per 10,000. But a few years ago, the National TB program noticed that they are having cases. And in 2017, they tried to did an assessment that showed that in 2017, they have 110 cases, and the GSD was 20% of that year, and the previous years were all above 10%. And the global average was 6.6%. Out of the 110 in 2017, 72% were MB and 4.1 were children. And there were overall 40% of women. And this shows that Sierra Leone continues to have leprosy cases. However, unfortunately, no study has been done to know the exact distribution of leprosy in the country. And the newly found leprosy cases have deformities and disabilities and children, which shows that transmission is ongoing. Unfortunately, the health system of the country is heavily constrained and in resources, and leprosy the activities of leprosy seem to be neglected. And these are people, most of the people that are affected by this leprosy are the poor, those are in the rural areas. So the GLRA and the National TB program wrote a proposal, and they said they want to try to introduce a traditional healer to work with a health system to see how best they can do a referral system, since traditional healers, traditional practice are well prevalent throughout Sierra Leone, and the traditional healers has been seen as the first contact point of the healthcare in the country. So this project will collaborate with the health workers and traditional healers to establish a referral system. And at the end of the project, they will try to evaluate the impact of the referral system. The rationale for this is because the disease still remains a public health problem, and there is a huge risk that many cases are being missed because of the distances. It's only 183 facilities out of 1,284 that are providing leprosy services in the country. And so they want to remove the barriers that they think is delaying the diagnosis of the disease, and they want to gather information on the fact of the delay in the diagnosis so that they can use the evidence that's been found in order to progress in how to detect cases early. The aim of the project is to establish a referral system between traditional healers, and this will help to fulfill the human rights aspect of healthcare by reaching every person, early detection, early diagnosis, and treatment. And the objectives are to determine whether this referral system reduced the delay of diagnosis in the country, to determine whether the referral system reduced the number of patients already with disabilities, and to determine whether the referral system helps to find hidden cases in the country. The location we have, this is the study design. It's an observational studies, and it's going to be in the intervention and controlled. We have 5 districts for the intervention and 6 districts for the control. And the study population, we have 140 traditional healers, 28 per each of the 5 intervention districts. And we have the presumptive cases that are being identified in these cases, in these areas. For the methods, we have year 1 and year 2 was the planning, preparation, and implementation. Is the pre-intervention, wherein we did a lot of extensive sensitization in all 5 intervention districts. And there were subsequent training for all the stakeholders, and there was an introduction for a session for the introduction of the referral tickets, referral system, and the screening tools for the traditional year. Year 3 and year 4 was the midterm evaluation and adaptive measure year assessment of newly diagnosed patients that have been diagnosed, have been assessed with the delay questionnaire. We did focus group in discussions, and then for the year 4 will be for the final analysis and interpretation of data, dissemination, and final project. The sources, the qualitative responses from interviews and qualitative from the quantitative national database for the leprosy. And the data collection tools were semi-structural questionnaires developed to interview stakeholders to get their views on the delay in diagnosis, and a prospective review of the surveillance records on tools for accuracy and consistencies. For the management and the analysis, we use the Microsoft Excel to enter and analyze our data and reports in, and we use the descriptive method to analyze the qualitative attribute thematically. The ethical considerations is the researchers took permission to access the TB database, wherein we have the leprosy database, because TB and leprosy are co-managed in the country. Confidentiality was maintained throughout the country. The expected outcomes that we are expecting that the number of referred hidden cases found in the intervention district will be higher than those in the found in the passive control district, and the number of referred cases with disability are higher than in the intervention than the control district. Cases confirmed from the referral system in the intervention district should be higher than those confirmed in control district. And children confirmed from the referral system in the intervention district should be higher than in the control. More women should be detected in intervention than in the control. So now the status in year one, well, this is what we did. The protocol was submitted, development of data tools, we pilot, we do the consultative meeting, advisory committee meetings, and we advertise the core team positions. Despite the delay in the pandemic, in year two, we did advisory committee meeting, we trained the traditional stakeholders, and we introduced the logbooks, and we recruited all the members of the team. So for year three now is where we left in 2001 was we did the advisory committee and we collected data. There was delay in collection data, but data was supposed to have been collected in 2020. Unfortunately, because of the pandemic, we did not collect data then. So it was projected to 2021. So we did some stigma assessment, focus refreshers training, quarterly supervision, biannual meetings, well, both traditional and regional supervisors. Our results. In the intervention district, as you can see, we have like 99 cases. And this is the case detection rate per 100,000. As you can see in the intervention, the percentage of the MB as against the PB, and this is the PB and the number of children. This is for the intervention district, the total number of cases is 92. And then these are all the others, as we just said, for the percentage for the MB, PB, and cases. And we should bear in mind about the control district. If we can see the population for the control district is 4 million, as is almost 2 times the intervention district. So now the number of referred cases, as we can see, we have 202 cases, which is 89 cases above the average normal cases that has been detected in Sierra Leone for the past years. And for 49% of those cases, we have been detected by the intervention district and the control. And the 7% is for the other districts that are not involved in the studies. And therefore, this you can see this is the 99. It means there's a difference in the case detection. But we don't think it's statistically significant. However, we will know by the end of the study. But we want to ensure that the population difference is quite great, as the control districts have twice the population of the intervention district. So we try to assess cases per 10,000, as you can see, and 100,000 and 1 million. As you can see, still the intervention district came out with higher cases than the control district. The number of referred cases with disability 1 and 2, we can see the intervention district has more cases in grade 1 and grade 2 than in the control district. And children that are confirmed from the referral system, the intervention district and the control district, we have more children that are detected with disability too than the control district. For the women, there is an equilibrium in the case detection in both intervention and control districts. But when we did the percentages as per the number of population, there are more cases in the control, more women detected in the control than in the female. So for year 4, we would have to continue to repeat year 1. Because this is going to be, year 2022 is going to be the year for the second implementation year, wherein this is the second, so we do exactly the same what we did in year 1. So our way forward, so we would still continue with the activities, the stigma assessment, then we have to assess the stigma within the before and after, and then for the focus group, and then we'll finalize the results and everything. So for the conclusion, the referral system has some effect with intervention, identifying more cases and control. In the intervention district, more grade 1 and 2 are detected. Children are more diagnosed at a higher rate in the study area than in the control area. And there is an equilibrium in the number of female detected in both intervention and control districts. I want to thank the Ministry of Health, LRI, National TB Program, and all other stakeholders that have supported this program. Thank you.
Fantastic, Mrs. Josephine. Thank you very much. Dr. Sunil, any question from the audience?
We have 2 questions. One from Ruth Butlin: will referral of patients mean potential loss of income for traditional healers? That's the question. Question 1.
Come again, I don't get you clearly on that one.
Well, it says, will referral of patients mean potential loss of income for traditional healers?
Yeah. Okay. Yeah, let's move on. Next one. This is somehow a loss for traditional healer, but before on the planning, there is a remuneration for traditional healers per case that is being given a compensation because we know they are losing money. So we are giving them a remuneration per case, by each case that they refer, which is very encouraging for them. So that's why we keep having cases. Okay.
Then there's a question from Claire. She says, did you have to incentivize the local healers? Okay, I think it kind of answers the yes. What you've said just now answers the same question. Did you have to incentivize the local healers, etc.?
Yeah.
Other than that, there are no questions. There was one question from Martin, but that was for the previous session. Martin, we will take up that question at the end of towards the end of the session. That's about it.
All right. Thank you.
Okay, thank you everyone, and let's move on for the last presentation, and I'd like to welcome Mr. Aubin Yao. Mr. Aubin, your camera is off. It's off for me, please. Mr. Aubin. Previously he had some technical problems. Let's see if he comes.
While we're waiting for Aubin, can we pick up those 2 questions?
Exactly. Yeah.
So this question is from Martin to Dipak. It says, please explain the key difference between the yield of the 2 approaches, and how did you manage to maintain confidentiality?
The later part of the question I couldn't understand.
Well, it says, how did you manage to maintain confidentiality?
Confidentiality. The confidentiality is maintained. I mean, giving the answer to the last question first and then first question last. Confidentiality is usually maintained as we maintain in our program. By these questions, consents, everything are kept confidential in our clinic. So it is handled by our staff only, not other people. So that is how we are keeping the confidentiality. That is one. And regarding the yield, at this moment, we just calculate, we see that number of patients we are having from intervention areas and control areas, because population and districts are more or less same at this moment. But we are collecting the data and we will analyze it later on with the population wise, how much cases we are getting from how much population.
Thank you, Dipak.
Thank you, Dr. Dipak. Oh, he's here. Hello, good morning, Mr. Aubin.
Good morning.
Are you ready to start?
Yes, I'm ready. Sorry, I got some issues to connect.
No problem. We understand
Okay.
very well. So Mr. Aubin will present the project title Integrated Approach with Skin Camp, eSkin Health App, and teledermatology in early detection, effective management of skin NTDs in Côte d'Ivoire. Mr. Aubin, as long as you're ready, you can start, please.
So good morning, everybody. My name is Aubin Yao. I work for Hope Commission International in Côte d'Ivoire. Slide, please. The title of my presentation has been already given. So we'll go through an introduction, the progress today, key findings, important and relevant findings, and the future plan. Slide, please. Obviously, we are implementing leprosy program in Côte d'Ivoire because the country is endemic, but also we assume that there's likely incomplete case finding in the reporting. And also from our past experiences, we can see that there are some challenges for case detection of skin NTDs, such as the high relevance of skin diseases. Also, the challenge of continuous case management. The cases are not continuously managed, but also there is a acute lack of dermatologist experts at the peripheral. Slide, please. The objectives of the project, the primary objective is to evaluate an integrated surveillance approach. And there are three secondary objectives. One is to increase case detection of skin NTDs. The second one is to improve knowledge of healthcare providers. And the third one is to develop a system to support healthcare givers at the peripheral. Slide, please. And the project site is Zwanwe. Zwanwe is in the west of the country, at the border of Liberia. It's an endemic district for long now. Is one of the districts which remain endemic despite the progresses. And you can see some of the pictures of cases we have detected since the beginning of the project. Slide, please. So in our methodology, we have two approaches. One is repeated cross-sectional surveys. Like each year, we organize at least one skin camp, where the program, leprosy program team, the NGO team, and other experts go to the field to support the field actors in active case finding. And the second one is year-round. The second one is the year-round case detection using the Skin Help app, which is teledermatology, having experts from Abidjan can support people in the field. And we can see how our case detection system is organized. We have some community survey. We use also the teledermatology through the Skin Health app for early case detection. So this enable local capacity for sustainability, and also it's enable diagnosis support in case detection and management. And we conduct training So this is an integrated surveillance approach using teledermatology and skin camps. Go ahead, please. So let me explain a little bit how the skin health application looks like. It's the tablet and web application, which enable to carry, I can say that the patient charts, because it is electronic charts within the tablet, and also it's enabled teledermatology because expert dermatologists can provide advices from remote. Also, it's the system system which can be used both online and offline. This is very innovative because most of the existing teledermatology application work only online, but this skin care application can be used offline. But for the data to be shared, we need internet connection. So each patient has his health file within the system. All the information and also clinical photos are in, which can help. And it's for now, it's in English, French, and Japanese, and the development is in progress. We start. Go ahead, please. So for now, we started in 2019 with the project launch, and we started with training, introducing the project to the district. We train nurses, and in 2020, we organized 2 field visits where we train nurses in dermatology to diagnose and manage skin NTDs, but also in the use of a skin care application. And we couple those trainings with skin camps using the tablets, and also by evaluating what we have done from the previous we got some difficulties with the internet connection, so we had to repeat the trainings and also try to solve the problems. And we organized skin camps in 4 villages. And in December 2021, we added 10 more nurses because the project target 20 peripheral health clinics. So we added 10 more nurses, and then we trained all the nurses again. Initially, we trained them in specific NTDs like leprosy, biliary ulcer, lymphatic filariasis. But later we discovered that during the initial training, nurses got only 20 hours of dermatology training. So we brought expert dermatology to the field to train furthermore those nurses in how to manage skin, identify skin lesion, and diagnose skin diseases. This is what we did so far.
Okay, this was your last slide, I believe.
Hello? Can you move on?
Sorry,
Next slide.
there was more.
Okay, so in terms of results, we'll see the results related to the objectives. In terms of case detection, we diagnosed 965 cases of skin NTDs. Most of them, majority of them are scabies, 97%. Also, during each skin camp, we diagnosed an average 850 cases of skin diseases, and we identify 104 different skin lesions. Also, we notified cutaneous leishmaniasis and mesotoma, which are very rare in Côte d'Ivoire. The country has not been recognized as an endemic.
No sound.
Yes, we have only 1 minute last. Mr. Aubin.
Leprosy cases for now, and 900 scabies cases, 18 years. So you see that the number of cases increased from year to year. From 2019 to 2021, the number of cases has increased. Go ahead, please. Next slide. In terms of knowledge and capacity of peripheral healthcare providers, as I said, through trainings, we have seen that the number of cases registered in the tablet has increased because initially they faced difficulties to use the tablet, but also to diagnose. But you can see on this graphic that the number of cases registered has increased, and mainly in 2021, they are more at ease with the tablets and the application, and most cases are now being registered. Next slide, please.
Mr. Aubin, we have only 1 minute.
Okay, so in terms of support to healthcare providers, this chart is done based on the usability survey which we conducted, and we have seen that the nurses are more at ease in using the application. Next slide. So in terms of important findings from our project, the local healthcare providers are not empowered, and they are using more and more the teledermatology, the skin care application for better patient care, and also they improve in terms of diagnosis. But we need longer study to measure the impact of the application. Next slides. I think the last one. So the future plan is here. We need to align with the national data collection and analysis the clinic data collected. And also we need to increase the number of users of the application to have more information on the usability and the effectiveness of this application. I think that is all. Next slides. Thank you very much for your attention, and sorry again for my delay.
Thank you very much, Mr. Aubin, for your report to be connected and for your presentation. I think we have many questions, Dr. Sunil. Did you manage them?
Yes, I think we have 3 questions as of now. There's a question from Barbara. She says, is the eSkin Health app validated?
Not yet. We are still developing, but also it's shared with the national programs. We are improving. It's not yet validated.
Question from Paul Saunderson. Do you give treatment for all these skin diseases? Are people satisfied?
During the skin camps, we give treatment. At least, you know, the treatment for skin lesions, sometimes it takes long, but we give the initial treatment for all cases diagnosed. And then they can continue with treatment if the first medication which we gave is not enough.
And a question from Martin. What measures do you have in place to protect patients' information and pictures in the Skin app and over the internet?
In the Skin app is not an open system. They have a different level of access. So it works exactly like the paper folder. So a nurse can see only cases it has registered. Then the people at the district level can see only cases registered at the district. Because we have login and password for each user. And the access depends on the level of the user in the health system. So it's not an open data system where anybody on the internet can go. You need access, and the access depends on your position in the health system.
Thank you. I think there are a whole lot of new questions that have come up. Patricia, do we have time?
We still have 3-4 minutes, maybe one more question from the audience or for you, Dr. Sunil.
Okay. What could be the reasons for 0 cases of yaws in 2020 and 2021 after having as high as 18 in 2019? That's from Ngozi. Sorry if I'm not pronouncing your name right.
One of the things before 2020, the year's cases were not biologically confirmed. So the 18 cases in 2019 were not from the project, but were based on the clinical observation diagnosis, not confirmed cases. But from 2020, all cases have to be confirmed according to WHO guidelines. This is why now we have 0 cases, but the 18s are not biologically confirmed cases, but clinically suspected cases.
Okay. We have time? There's a question from Ruth. From Ruth Butlin, do you have constantly available an expert for telemedicine consultations who can deal with any skin NTD?
Yeah, we have 3 dermatology professors involved in the project. The Bureau program director is a dermatologist professor, and the Ralph Loro Institute director, and another professor from Wake University. And they are very committed and available. Every day they confirm, they synchronize, they can see cases. And then the system is set in such a way that within 48 hours, they have to confirm the cases. And right now, even more, we continue to have some meeting with the users to improve quality of photos. So they just not only confirm cases, but also they provide advices in terms of photo taking and the kind of information they have to enter. So they are very available, and we are lucky for that.
There are some questions on the very low leprosy numbers. Reasons, can anything be done to improve that? So, Aubin?
One, we are not covering the entire districts. We have around 33 peripheral clinics. We started with 10, then we have 20. So it's one of the reasons. The other reason is the fact that even during the skin camps, some of the leprosy cases do not come. It's not, they don't show up. So, but also in general, the number of leprosy cases is decreasing in this area. So those are the reasons I can give for the low number of leprosy cases. So by covering all the districts and repeating the skin counts, we can have more cases.
Thank you.
They are there.
Thank you.
Okay, so we end the session. I would like once again to thank Mr. Aubin, Mrs. Josephine, and Dr. Dipak for the presentations, to thank the co-sharing, Dr. Sunil. Very good to work with you, and Nicole and Nick, the Leprosy Research Initiative team, and all the audience for the participation. So wish you a very good day and weekend, and the next session.